So the Honorable Chairpersons and respected panelists and also the learned audience. Assalamu alaikum. Welcome to my presentation. I will talk about the wide complex tachycardia, how to intervene. So the wide complex tachycardia is one of the most common presentation in our clinical practice, day-to-day practice, and a bit challenging for all the physicians, and especially for the cardiologists and cardiac fellows who are attending in the emergency department and also ICU and CCUs. So before going to the details, let us start with some case scenarios through which the presenting in our hospitals. The 32-year male was presented to an ICVD with the complaints of the palpitation for last 2 years, and also there is no history of chest pain and shortness of breath, and having history of recurrent hospitalization with these symptoms. In the emergency department, the ECG was showing that there is a rate is very high, around 280 beats per minute, and the rhythm was regular, and there is some QRS complex is very wide, about 200 millisecond, and there is some P waves are present which is dissociated from the QRS complexes. So our initial diagnosis was the wide complex tachycardia, regular wide complex tachycardia. And as the patient was hemodynamically stable, the patient was injection amiodarone was given and reverted to sinus rhythm. In the sinus rhythm, the ECG was showing that the T wave inversions in the V1 to lead V4. And subsequently, he was diagnosed as a case of ARVC according to the echocardiogram and cardiac MRI, and subsequently managed by ICT implantation. Case number 2, that is the Mr. X, 30 years old young male, admitted to an ICVD with the complaints of the palpitation for the 1 day and vertigo and dizziness for the few hours, and having the history of similar symptoms for the last 2 years. In the emergency department, the ECG was showing that the QRS is very wide and the rate is very high, around 200 beats per minute, and the QRS morphology is variable. Some are wide and some are narrow. So our initial diagnosis at the emergency department, it was the irregular wide complex tachycardia, and the patient was, as the hemodynamically unstable, he was cardioverted, and after cardioversion, the ECG was showing there is the PR interval is very short and the delta wave is present and QRS is very wide. So our diagnosis was the WPW syndrome with left free wall accessory pathway, and subsequently the patient was successfully ablated. Case number 3, there is a 61-year-old man presented with the chest pain, suddenly developed collapse in our emergency department, and the ECG was showing that there is sudden onset of the very irregular chaotic bizarre QRS complexes, and patient was hemodynamically unstable, and immediately defibrillation was done, and the ECG was showing that the ST segment elevated in the 1 AVL and V4 to V2 to V6, and diagnosed as a case of acute ST elevated MI, and patient was thrombolyzed with streptokinase, and accordingly subsequently CAG was done and followed by the PCI. So these are the scenarios the patient is presented in our hospitals in our every emergency period. So now we enter in our details in the wide complex tachycardia. What is wide complex tachycardia? There is the heart rate is more than 100 beats per minute, and the QRS duration is more than 120 millisecond in the more than 3 small boxes in the QRS in the ECG papers. So what are the differential diagnoses? The differential diagnoses are commonly the regular and irregular. So the regular wide complex tachycardias, among them is ventricular tachycardia is the most common presentation, more than 80% cases. And others are the supraventricular tachycardia with the pre-existing bundle branch blocks, SVT with aberrant conduction, or SVT with pre-excited tachycardia, that is the antidromic AVRT or WPW, and some drug-induced widening of the QRSs and the electrolyte imbalance, that is the hyperkalemia. And others are the pacemaker-mediated tachycardia, and artifacts are at the bottom of the list. And the irregular, among them atrial fibrillation or the atrial flutter or atrial tachycardia with varying block is the commonest cause, and also the pre-excited atrial fibrillation, which I have mentioned earlier. And the polymorphic VT includes the torsa and also the ventricular fibrillation, and also the artifacts are there. So, the approach, how we will approach, because this is a very life-threatening condition in our setting. In some patients are occasionally their life is in danger. So we have to have our idea to diagnose it as early as possible to get rid of that malignant arrhythmia. So, and we can save our life of the patients, and also we can plan the further management in the long term. So we approach through some clinical substrate, that is the clinical history, physical examination, and also some ECG findings. In clinical substrate, that is the history of prior heart disease, more goes favor of ventricular tachycardia. And also the first episode after MI is more likely VT. If it is older the age, more than 35, it is VT is more likely. History of similar episodes for several years, SVT is more likely. And having the family history of sudden cardiac death like HOCM or ARVC or long QT or Brugada, so the more likely the rhythm should be the VT. And history of pacemaker or any ICD, the most probably the diagnosis would be the white complex tachycardia for that reason. And also some drug history we can. So we can differentiate from history what will be the causes of the white complex tachycardia. It is from the drug, it is from the pacemaker, or it is from the electrolyte imbalance, or having history of the previous history of hospitalization of similar onset. So if the whole things depends on the hemodynamical stability, because if the patient is hemodynamically unstable, no matter what is the rhythm, what is the tachycardia is, whatever, we should go for save the life. We should go for the defibrillation or a cardioversion. If the patient is hemodynamically stable, then we can proceed further. What is the history, what is the physical examination, and also the ECG findings. In the physical examination, we will search for the AV dissociation, which is manifested by the Canon waves in the JVP, which is irregular, and variable intensity of the first sound, and the variation of blood pressure, which is unrelated to respiration. Then we compare the normal sinus rhythm ECG. This is very important, whether the normal sinus, we search for the normal sinus rhythm ECG, whether there is the presence of ischemia before, the presence of acute MI or old MI, this Q wave MI, or any LVH, or there is long QT, or any epsilon wave, or previous pre-existing bundle branch block, or any pre-excitation, or previous atrial fibrillation. Those will help us to diagnose the white complex tachycardia, and we can differentiate it very correctly. So ECG, before going to diagnose the white complex tachycardia, we should ask the patient to do a 12-lead ECG. Always we should do a 12-lead ECG to diagnose the white complex tachycardia. So our next step to diagnose to find out the ECG findings which differentiate the white complex tachycardia. So the hallmark of the ECG findings, the 5 hallmarks are present. All of you know that the AV dissociation, the first one is the AV dissociation, which is very specific for the white complex tachycardia, ventricular tachycardia to diagnose. And the fusion beats and capture beats are the next one. Third one is the very wide QRS complex, that is more than 160 millisecond in LBBB, and if it is RBBB, more than 140 millisecond. And some precordial concordance is the next one. And the final one is the shifting of the QRS axis. So one by one, I am showing you that this is the AV dissociation, that some P waves are present among the QRS complexes. Sometimes very difficult to find out, but we should search for it, because if it is AV dissociation is present, atrial rate is less than the ventricular rate, some P waves are present within the QRS complexes. So it's very, very specific for the diagnosis the ventricular tachycardia. So in the lower panel, it is showing that there is P waves are in the middle of the QRS complexes. So this is the AV dissociation. This is the white complex tachycardia, not that much wide, a bit narrower, but there is the rate is very high, but among them, some P waves are present within the QRS complexes. So this is the AV dissociation is diagnostic of VT. So the QRS, though the QRS complex is narrow, it is a narrow complex, looking like narrow complex tachycardia. So it is coming from the ventricular septum. There is the posterior fascicle, most likely the posterior fascicular VT. Next one is the capture and fusion beats. Some P waves are capturing the ventricle and producing the narrow complexes. The narrow complexes within the white complex tachycardia is the diagnostic of VT. narrow complex tachycardia, SVT never produced the narrow complex tachycardia within the wide complex tachycardia. So the narrow complexes within the ventricle in the wide complex tachycardia is the diagnostic of the ventricular tachycardia. So the P waves are some sinus impulses is capturing the ventricle. So the complex is very looks like to normal P and QRS complex, and some P waves are capturing partially the ventricle and partially by the ventricular, is fused with the ventricular complex, looking like a fusion bit. So these are the pattern of the fusion bit. This is the capture bit of the absolutely normal looking. In the ECG, in the very wide complex tachycardia, that is the QRS is very wide. In the lower panel, we are observing that in the long lead, the presence of some fusion bit, and this is the capture bit. Normal looking, P wave is followed by QRS complexes. And next one is the widest QRS complex. QRS complex is wide, that is more than 160 millisecond in case of LBBB and more than 140 second in case of RBBB. And we should assess the QRS complex. In the largest QRS complex, we will measure. In this ECG, in chest leads, there looks like a very narrow complex QRSs. But in the limb leads, the QRS is very wide. So we will measure the QRSs from the widest among the limb leads. So this is the next one is the precordial concordance. That is the positive precordial concordance and the negative precordial. Hey, do you have the pointer, please? No pointer. Okay, in the lower panel there is a negative concordances. So this is the diagnostic of ventricular tachycardia. And next one is the last one is the QRS axis. So the shifting of the axis, any major shifting of the axis, more diagnostic of the ventricular tachycardia. And in the northwest axis or right superior axis deviation strongly suggests the ventricular tachycardia. If the axis is the upper right quadrant, so the ventricle, so the rhythm will be originated from the apex, and the apex is formed by the ventricle. So the ventricular tachycardia is most likely. And the significant shifting, there is more than 40-degree shifting suggests ventricular tachycardia. And the most commonly the RBBB with left axis suggests the ventricular tachycardia, and LBBB with right axis suggests the ventricular tachycardia also. And RBBB with normal axis strongly suggests supraventricular tachycardia. Let us see one by one. There is the RBBB morphology. QRS is narrow, and this is the left axis deviation. It is diagnosis of the diagnosis is ventricular tachycardia, possibly fascicular VT. And this is the left bundle branch block morphology, and the right axis deviation is suggestive of the ventricular tachycardia. And some differentials of the left bundle branch block and left axis. LBBB morphology and left axis having the three differentials commonly. There is the supraventricular tachycardia with the pre-existing left bundle branch block, and the Maheim fiber tachycardia, which we encountered in our EP department. And another differentials is the bundle branch reentry VT. These are the three differentials of the left bundle branch block with
2
left
minutes
axis
left.
deviation. Okay, thank you. And then if we cannot diagnose the 5 points we have mentioned, then we go for the algorithms. The commonly algorithms which differentiate the wide complex tachycardia are the Brugada algorithm and the Verrecke algorithm, limb-leads algorithm. So in Brugada algorithm, all of we know that some steps, 4 steps are there. First step is the QRS complex. Absence of QRS complex looking like this figure is more likely the VT. If the presence of second step is the QRS, if RS is present and RS duration is more than 100 millisecond, it is favor of the ventricular tachycardia. Next one is the AV dissociation, which I have mentioned. If it is present, it is VT. Not present, we will move to the step 4. Step 4 is the morphological criteria. If it is LBBB morphology VT, then we will go for the RS duration. Small r is more than 40 millisecond, it is, and the descending slope having the notch known as the Josephson sign, it is more go favor of the ventricular tachycardia. And Q wave is always present in the V6, more go favor of the ventricular tachycardia. If it is RBBB morphology, and the taller left rabbit ear is the diagnosis of the VT, and if it is the taller right rabbit ear goes favor of the SVT with right bundle branch block morphology. And next one is the Verrecke algorithm, which is a very authentic and newly published, and it is the AVR only one lead, depends on the one lead, The Burgard algorithm depends on the precordial leads, and the Vericke algorithm depends on the only one lead, that is the AVR. If it is northwest axis, positive R wave is present, so it is the goes in favor of the ventricular tachycardia. If it is not present, further steps will be there. I will just skipping as a short of time. The SVT with aberrancy, it is more likely if it is the bundle branch block morphology is similar to the broad complex tachycardia, more goes in favor of the SVT with aberrancy. It is previous ECG showing the WPW pattern, more goes favor of SVT. And patients having the paroxysmal tachycardia and terminated by adenosine and vagal maneuvers, it is SVT with aberrancy. So another case example is the patient presented in our EP department, that is the white complex tachycardia, LBBB morphology and the inferior axis. It is a diagnostic case of RVOT VT and was ablated successfully. And the another patient presented with the in our hospital, that is the QRS is absolutely RBBB morphology and inferior axis, and that is the right rabbit ear pattern, and after the injection amiodarone reverted to absolutely RBBB and the similar axis. So it is the SVT with pre-existing R right bundle branch block morphology. And the I am skipping some. So this is how do you interpret this ECG? That is the QRS complexes in front of that. That is the pacemaker spike. So it is the pacemaker-mediated tachycardia. And these are some ECG that is showing the artifact which is commonly present. Artifact is identified by the notches signs. This is the notches sign, presence of some notches, presence of notches in the similar interval of the RR interval, by which we can diagnose the artifacts in the ECG. So that's all regarding the management. I have already mentioned the acute management and some long-term managements. That is the, if hemodynamically unstable, the patient will be treated by the cardioversion, and if the chronic in atrial fibrillation, pre-excited atrial fibrillation, and the chronic management, there is some drugs, there is class 1 and class 3 drugs, and in the ICD and EPS having the great role for the standard treatment of the white complex tachycardia of SVT with aberrancy. So that's end. Thank you very much. My take-home message is always try to take the 12-lead ECG and do not diagnose an ECG in isolation. Please try to clinically correlate. White complex tachycardia, usually 80% cases VT. Sinus rhythm can solve our problem. And history of myocardial involvement more likely VT. And whenever in doubt in white complex tachycardia should be taken as VT. So before going to end my session, I would like to thanks to the organizer, and also my thankful gratitude to my mentor, Professor Mohsin Hossain sir, because I have learned a lot of things and learned a lot of ECG techniques from him. So thank you everybody for patience hearing.